think, is our leadoff hitter here, and I see that you have PowerPoint prepared, which is great. Do you want to just start with that?
That would be great.
Yes. Commissioner Kavanaugh, I'm chairman of the Health and Human Services Committee. Today's committee hearing, subject to the open meetings law, a copy of which is posted on the wall here. We're joined by Commissioners Morgan and Duda, and our agenda is posted as a public record. It contains the state of mental health services. We are joined by the CMHC Director, Sherry Glassnap, who is going to deliver her presentation. Thank you for coming.
You are very, very welcome. I'm trying to keep this somewhat informal. Last time I presented, I did an overview of all of the services at the Douglas County Community Mental Health Center that we provide. And so what I chose to do for this presentation is to pull out some services that we have and try and do a highlight on those specific services that we provide. So I do not have this committed to memory, so please bear with me as I try and point some of the information out. I wanted to start with Triage Therapy, which is one of the services in our psychiatric outpatient clinic. We began the Triage Therapy services in October of 2016. This recommendation came out of an MTM study that we participated in that was fully funded by Region 6 Behavioral Health Care. So this learning through the collaborative efforts through MTM did not cost the county anything. And the first triage therapist was fully funded by the Behavioral Health Support Foundation. So again, no cost to the county for this. We expanded it, it went very well, and so the Behavioral Health Support Foundation approached us and said, we think this is a great project in the community. It's making a significant impact on individuals' lives, and we would like you to expand it. So in August of 2017, we expanded again through additional funding from the Behavioral Health Support Foundation. We chose to collaborate with the General Assistance Primary Health Care Clinic to try and help meet the behavioral health needs within their clinic. And Carly, who is our second triage therapist, is actually officed in the primary health care clinic. And it's been really phenomenal to have her there. She can screen individuals' behavioral health needs, help make a determination if they can continue to have services in the primary health care clinic, where their primary health care providers will oversee their medication regimen, or if they're in a situation where they need to be referred to the outpatient clinic due to the severity of their symptoms and need to be seen in that specialty clinic. To date, we have seen a total of 1,510 individuals. They walk in. This is open Monday through Friday, so it's not scheduled. They come in with whatever meets their need. The average wait before we had triage, before somebody could get into our clinic, was 30 to 60 days. And since adding triage, from the point they see the triage therapist to the point they get a medication management provider, is down to 8 days. So it's been very good. Part of the reason is that triage therapist really can sit down with the person and spend anywhere from an hour to 2 hours to try and figure out what their exact needs are. Sometimes the individuals are so symptomatic, they get referred to our inpatient clinic. We may try to funnel them directly into our day treatment program. We may start standalone therapy with individuals to see if that helps them, or med management. So it's really helped streamline our process. We do a survey with our triage therapy clients, so we can get input from them. And some of the information that we thought was interesting is 7% of the individuals said that if we didn't have this service available, they would have gone to an emergency room to try and get their needs met. 63% reported that they wouldn't have sought out services at all. 21% said they would have tried to go to another agency, and we know the wait in the community is significantly is significant in the community for med management. 76 report that they didn't have any resources to pay for services. So as kind of the service of last resort for the indigent, I think this is a really nice safety net that the county has. 88% reported that they were concerned that they wouldn't have been okay without the services that they received that day. So in regard to their mental health stability. So that's some of the information that we track from Triage Therapy. Before I move on, any questions about the Triage Therapy?
How many people do this? How many people are triage therapists on your staff?
We have 2 triage therapists.
And what is their education background?
They are licensed independent therapists. So they're
Okay.
therapists that have that extra level of credentialing and can see people independently versus having to have a supervisor. One of the questions that has been brought up with us is, why did you not do a triage APRN instead of a therapist, somebody who could go directly to a prescriber? Well, the nice thing about the triage therapy, again, is they kind of help determine what services the individual needs, not only internal but external, and they're about half the price of an APRN. Our average length of wait to get into an APRN is still extremely low, so we think that it's a more cost-effective model.
Thank you.
Okay. The other service I wanted to highlight is our intensive outpatient program. If you remember right, this program was initially a collaborative effort between Douglas County Community Mental Health Center and Douglas County Corrections. And it was, I think it was a 3-year grant initially. And upon the grant ending, we were able to secure intensive outpatient funding through Region 6 Behavioral Health Care to continue this program. This program operates both in Douglas County Corrections and their reentry side, and then we also have this program operating at the Community Mental Health Center, the 41st and Woolworth location as well. So just some basic information about the clients since June 2015 to December of 2018, some demographic information. Really what I wanted to highlight is the number of individuals that have graduated. So 21 in 2015, 54 in 2016, 55 in 2017, and 52 in 2018. With this program, one of the things that makes it very successful is we have a 6-month case management program that follows them after graduation to provide them with some additional support and to try and help prevent recidivism back into corrections. That's our goal with this program. So 150 clients have completed that 6-month post-case management. 90.6% have had a success rate, and that is that they haven't picked up any new charges and not ended back up in corrections. So why is it so important that Community Health Center, our behavioral health care services, interface with Douglas County Corrections? I think all of us around the table probably know that answer. To try and help reduce the recidivism, to try and help meet the growing population of individuals in corrections with behavioral health needs that aren't being met. So we also are working with the Familiar Faces Project. Again, we had one individual who completed the IOP program successfully. She also successfully completed probation. She now works within a substance abuse service that is in the community, and she is very active in AA. So she has gone from corrections, homelessness, not having an income, not feeling like she's a productive citizen, to now working in the community, feeling like she's being a very productive citizen. She also recently got married, and she credits her recovery and to the support that she received in corrections and the reentry program through IOP and also through AA.
Okay.
Social detox. So we've had this program for a little over, it's almost 2.5 years. I really wanted to focus with social detox. I wanted to focus on the client's satisfaction surveys, because these really, truly, I have a hard time explaining and describing the nature of the individuals that come to us in detox. These are individuals who really truly have, when you hear the old-fashioned terminology, bottom of the barrel, which is terminology I don't like, that really is the population that this program is meeting. These are individuals who are chronically homeless. These are individuals who have burned most of the bridges with their family and with their friends. These are individuals who are not employed. And these are individuals that a lot of programs in our community have kind of turned their back on. They've maybe gone through programs several times, they have not been successful. And the goal of the program, it's two-pronged. In civil protective custody, it's to divert people from corrections, to follow the statute where public intoxication is no longer a situation where you're going to get picked up and placed in jail. Hopefully, if you're not safe, you don't have a safe place to go, you don't have family members to go to, they're going to bring you to the civil protective custody side of detox. And they can stay there 23 hours, no longer than 23 hours and 59 minutes. Our average length of stay is 13 hours. There's also the voluntary side of social detox where individuals can stay 3 to 5 days. So they can transfer over to that side. The goal is really to help people get sober. Pretty simple. Which are things that people that they haven't been able to do on their own. So I gave some quotes from our satisfaction survey. One individual talking about, this is the longest I've been sober. It's only 48 hours. It's not very long, but it's more than I've ever had, and I'm always going to cherish it. Staff were here to care for me. When I've been struggling, they've helped guide me through fear, anxiety, and emotions which were very hard to balance on my own. The extra attention and resources to my situation helped me feel safe. I came in with one goal, and while I was here, I made many goals and have a really good plan and understanding of what I really need to stay sober. Douglas County Detox saved my life. The compassion shown to me by all the staff, and they happen to name Donna, and then also just the help that they received to guide them through. I truly believe that you guys set me up for success in my life and recovery. Thank you. The other program that I wanted to focus on was our inpatient program. So this is the highest level of care that we have at Douglas County Community Mental Health Center. So this is our acute hospital program. We have the 2 units, 8 beds each. And over the last year, we've served 125 individuals in inpatient. The top 2 diagnoses, 41.94% schizophrenia or other psychotic disorders and 38.42% mood disorders. This particular statistic and the way it was sorted does not highlight the fact that most of the individuals coming through our program are also co-occurring. So they have both mental health and substance use issues. Well over 80%. Most of the individuals coming into this program are also medically compromised as well. So, but that wasn't in this particular statistic. The age of our individuals, the 18 to 64-year-olds, we served 812 individuals, 65 to 73, 13 individuals. And then we broke down gender, 340 females and 485 males within that program. Gaps. So individuals have asked me several times what kind of gaps our community has for behavioral health services. There's always a lot of gaps. There's never enough funding to provide the services that are needed in a community. But the gaps that I have felt, and this is my personal opinion, most significant is the regional center not having enough capacity. I truly believe, and I guess I would have to look to the county attorneys for that, but by statute, the regional center is responsible to provide that long-term care. And so as behavioral health reform took place and the Norfolk Regional Center closed and downsized and only serves a specific population, and the Lincoln Regional Center has dedicated beds to each region, but a lot of times those individuals are the priority from the regional center is to serve those individuals who need to go for competency evaluation and competency restoration. So those individuals in the wait list will trump the behavioral health individuals that are waiting for a bed. So even though they're waiting because there's not enough capacity, the behavioral health individuals are waiting as well. The last individual we had, I think, waited for about 2 months to get to the regional center. And as far as I know, he's still at the regional center. So I think that's one of the areas that the state could look at to see that there could be a better way to fund that, or to maybe open up another wing at the regional center or something like that would be wonderful. And then increased capacity telecare secure residential. That program is I'm going to use the terminology like a step down from the regional center or to try and help divert people from the regional center. Historically, they had 2 16-bed units. Now they have 1 16-bed unit. The last I checked, they had a very significant wait list of about 40 individuals. And that changes. It ebbs and flows as people remain in the hospital because they can't get to the regional center or they can't get to telecare secure residential. They maybe stabilize and then they get diverted to a community program, res rehab, an apartment, supportive services, outpatient medication management, and things like that. But those are 2 areas that I feel like the continuum is missing for capacity for behavioral health individuals with very chronic histories. I do not know why my slides got out of order, but they did. So since they did, social detox capacity, 26-bed facility. I apologize that those got flopped. 10 beds for involuntary and 16 beds for voluntary. Challenges that we face, structural mandates for the involuntary detox services, which we've talked about for about 2.5 years. Structural mandates by the state for peer support services, which we have talked about for a very long time as well. And I appreciate the support from the commissioners in regard to helping us be able to continue our peer support services in our inpatient setting. I think that's absolutely essential. And then meeting the needs for individuals with substance abuse issues. And it's not just substance use, it's their medical needs, the chronic nature of the clients that we serve, et cetera. Okay, so some of our goals, continue to improve the therapeutic environment on 5 East, looking at some different structural ways that we can provide the services there with the nursing shortage and things like that. Of course, try and successfully negotiate the mandates for social detox and continue to advocate to the division for a more reasonable service definition for peer support. Those are some of our continued goals that we at the Community Mental Health Center actively try to engage in with the region and the state. So that is my quick and informal presentation. Does anybody have any questions?
This is great. Anyone? Okay. I have a couple.
Oh, I thought I was off the hot seat.
And some of these are just category by category. So when we're talking the triage therapy category, what's the cost of that?
Can I get that information to you? Because I don't know that off the top of my head.
Okay. And then when we do this triage, is one of the outcomes a referral to inpatient?
Could be, yes.
Okay. When we're dealing with that large of a number, I think there's 1,510 walk-ins to date going back to when?
2016. So about 50 individuals a month, I think, is approximately what they see.
Right. They come in, there's an 8-day from walk-in to they get, a sit-down with one of our therapists?
One of our providers, so an APRN or a psychiatrist.
Okay, so they immediately get a sit-down with the therapist?
Correct.
And then there's an 8-day to the provider. What's that provider? Is that an MD or what is that?
It could be one of our MDs or it could be one of our APRNs. So the whole goal of getting them to that person is for their medication management.
Okay, and the overwhelming majority of these are medication management results, right? The intensive outpatient program, what's the cost of that?
Unfortunately, I didn't bring the cost of any of our services, but I will certainly get that to
Sure.
you.
And, you know, when we're talking recidivism, quantification of that is key. And I see that we've got, of the 150 that completed the 6-month program, 136 didn't pick up a new charge. What's the time frame of that?
I will find that information out for you and let you know.
Okay,
I believe it is a year, but I want to double check.
right. And do we track them beyond that time frame?
We do not.
Okay.
We could, I mean, we could pull a report.
Right. Well, I mean, recidivism doesn't end in, you know, any specific time frame, and so, you know, going forward, I mean, the 90% plus is very impressive, but then it's, you know, compared to what? What do we have over time is gonna be a key component to making sure that that metric is, you know, as accurate as possible. The social detox, which I think is a great service that we do provide, what's the cost of that?
I will get you the exact numbers. And do you want those numbers to be both the involuntary and voluntary together?
Right, and then maybe do a breakout of it too. But do you have a ballpark on that one? We assumed that, what, a couple of years ago now?
We did, 900,000.
Okay. And I think they indicated there's 26 beds there, 10 for the involuntary civil protection, and 16 for voluntary. So explain to me how that works out. I mean, people show up and, you know, some of them are brought by law enforcement, some of them show up voluntarily. Does that determine where you go, or how does that go?
It does. So when somebody is brought in by law enforcement, then they automatically go into civil protective custody. If somebody comes in on a voluntary basis, unless we have concerns and need to call the police, we try to have them go into the voluntary side of services. There are times though, when we're concerned about the individual, and we may call the police to determine if they need to be placed in civil protective custody.
And do you know the capacity? I mean, you know, we have this 26 beds, but are we, you know, like you would do on the health center, we're at X percentage capacity as an average. Do you know what that is?
I can get that information for you. Terry is pulling together information for our next Board of Trustees meeting in regard to the number of individuals served. I do know that we've served more this year than we did last year. But I don't know the exact number off the top of my head. And it's in civil protective custody, since the length of stay is so short, you see people coming in and out of that program all day long. You can do 5 admissions, and then within a few hours, you know, individuals are leaving.
Right. I think you did an average length of stay here someplace, didn't you, on this?
The average length of stay for the civil protective custody right now, I think I said verbally, is 13 hours. In the voluntary side, they can stay 3 to 5 days, and we are just over 3 days in that program.
And then when they get done with that period, the involuntary, what happens to them?
It depends on the person's circumstances. Some of the individuals agree to go over into the voluntary program and get additional support. Some of the individuals are released back to family members, or we've had individuals that, I'm gonna miss my flight, I came in for the College World Series. Those circumstances, they're rare, but they do happen. So unless they choose to stay from civil protective custody, then we have to release them.
Okay. the civil protective custody cohort here, would some of them have charges filed?
If they weren't in civil protective custody,
Well,
or
like I'm saying, the law enforcement brings them to you, but they filed a disorderly conduct on them as well.
no. So the whole goal for civil protective custody is for them not to have charges placed against them. If they were that disruptive and the police didn't think that they would be okay in civil protective custody, then they might get trespassing or disorderly conduct charges and then go to corrections if they're medically stable enough to.
Okay, so there's no like corrections hold on any of these people?
No, there is not.
So the legal authority for the civil protective custody is what?
By statute.
And what is that standard?
The statute actually is embedded in the alcohol statute, so it's kind of an interesting place for it to be. And it just basically was put into place to help decriminalize public intoxication in individuals who may not have a safe place to go if they were publicly intoxicated. And so it indicates that those individuals will be either taken to a family member if there is a safe family, if there's a family member to go to, or a public, a facility, like a treatment facility for them to be, to get to detox.
Okay. The psychiatric inpatient services that we do, these 2 units of 8 beds each, the 16-bed units, those are at 5 East?
Yes, so it's on the 5th floor, and at one end of the hallway, we have our psychiatric intensive care unit, which is a much smaller unit. And then we have 5 East, which is for individuals who are a little more stabilized, not as aggressive, not as violent, and that's a more open unit.
So when you say we have served 825 individuals, what's the time frame of that?
Average length of stay on that unit is 3 to 4 days, or on the between is 3 to 4 days, but we will have individuals who come in, they maybe are on an emergency protective custody, the doctors evaluate them, and they might leave within 24 hours, and then we have other outliers at the other end that we've had for 2 months. So it's an extreme range for individuals, but average is gonna be, for stabilization, is about 4 days.
Okay, and the max is what, did you say?
We had somebody for 2 months within the last year. That probably isn't our longest individual, historically, but that's.
So the group of 825 individuals, patients receiving inpatient services, over what period are we talking about? Over the last year?
The last year.
And the cost of that service?
I knew you were gonna ask that. I already wrote it down.
Okay. When we're talking about the gaps, I think that we all recognize that, there's not enough money to meet the need, but this mechanism whereby we treat people over a long period of time, and the gap that exists in terms of we don't have the local capacity for long-term mental health care treatment here, inpatient, is something that I think that you referred to came about in a reorganization, I guess, of mental health services that anticipated that the regions would use the regional center for long-term inpatient mental health care services. So we're Region 6?
We are Region 6, that is correct.
And our regional center is just ours, or do we share a regional center with other regions?
It is shared with all of Nebraska.
Okay.
So Lincoln, everybody in Nebraska will go to the Lincoln Regional Center. Unless you need, I believe that the Norfolk Regional Center focuses on sex offender treatment. So those individuals will go to the Norfolk Regional Center. So the Lincoln Regional Center is the only place where the Board of Mental Health committed individuals who are committed to the Department of Health and Human Services to receive treatment at the Regional Center will go to Lincoln.
And these are primarily used for people in that capacity, where there is some judicial reason for them to be receiving treatment. It's not like I show up and you know, I have a long-term mental health problem. I'm not under any Board of Mental Health order, or I'm not facing any charges or anything. I just need treatment. Those are not the people in the regional center. Correct?
No, those would be the individuals who are stabilized, hopefully stabilized in an acute care setting, like the communal health center, and then stepped down out into the community to some form of support services is the design. The individuals who can't stabilize in an acute care setting in that very short period of time and step down are the individuals who we see coming back frequently and do not stabilize well. Those are the individuals that end up being referred to the regional center.
But on what authority are they referred to the regional center? There's gotta be some judicial authority or
So
something?
there's typically there's a Board of Mental Health petition, and then there's a hearing, the Board of Mental Health hearing,
Sure.
and then the doctor makes a recommendation, the doctor testifies, and then the board determines, yes, they need to go to, they're committed to the Department of Health and Human Services and should go to the regional center, or no, they're going to be on a 90-day continuance and go to outpatient, or they're going to be committed, but it's going to be to outpatient services, and here's the recommended outpatient
Gotcha.
services.
And the legal standard there is, you're a danger to yourself or to others.
That
And
is
a
correct.
petition is predicated on that, you are entitled then to representation and a hearing. It's a judicial process. But someone who does not have a petition filed based on the danger to yourself or others, but they are acutely mentally ill and they have a long-term condition, there is no place for them in the regional center. I mean, they're not subject to any court order or Board of Mental Health order or judicial proceedings of any kind. Where do those people go in our community?
To a variety of services, if they have, if they meet the criteria and they can get authorization, it could be to Telecare Secure Residential. Community Alliance has residential rehab programs. There's assisted living facilities in our community. They could be in shelters, unfortunately, and receive outpatient services. There's just a variety of referrals that we make to the community.
Okay. So the existence of long-term mental health care beds for acutely ill people not subject to Board of Mental Health or any other judicial proceedings are, again, either shelters or what private capacity is there locally in our community?
For long-term services for individuals? Well, services are Medicaid services and Region 6 funded services all have to have an authorization. So the length of stay that individuals have are based off the authorization with the managed care companies. And that, again, that could be anywhere from the Telecare Secure Residential would be the highest. A group home, which we refer to as residential rehabilitation, would be the next. There's some assisted living apartments, and those are ran by a couple of different providers here in the community. They're intensive community support, and then there's a step down to that as well. There's the mental health respite program. A couple of private folks have opened assisted living facilities. So there's an extreme array of community-based services. It's just finding the right service for that particular individual.
Well, that's great, thank you. Back to this detox thing for a second. I think that you mentioned before that the detox service that we provide actually pays for itself because those people are not going into the correction system, and we pay a significant amount for people going into the correction system. Is that a fair estimation of how detox helps us financially?
I definitely think that it helps in regard to cost shifting probably, because there definitely is still an expense to the county for the detox services. They're not fully funded. We have a lot of mandates that require additional things that we do for that program. And then our most recent challenge is the reduction of the rate that the state has indicated for detox. And so right now, with that information being new, we're trying to put together financial information for a loss of $200,000 or $250,000, wherever it lands, and where are we going to come up with that additional revenue to support that program. So I think where we see the benefit personally as the provider of that service and the detox staff would say is the quality of life for the individuals who receive the service, that come out stronger on the other end of it. We had 2 years ago, we had somebody drop off an anonymous donation, we don't know when they were there, of $1,000, or if it was a family member of somebody who was there, because of the impact that program made on their life. So that's where we see the benefit to the county.
Thank you. Anybody else? Thanks a lot.
Yep, you're welcome.
Oh, sorry.
Yeah, before you end up.
Oh, Larry.
Along the lines of what I was saying earlier at the Douglas County Board meeting, some of this is a little bit confusing to people that are new to the topic. Like, are we really on the topic of behavioral health or mental health services, or a combination?
The language that's used by those of us that are professional, when I say behavioral health services, I mean both mental health and substance use. So it encompasses both mental health and substance use. Some services, by the service definition that's developed by the state, not by us, will tell you what's your priority population. So detox, they have to have substance use issues to come into that program. That's by the service definition. So some of those are based on your service definition. In the intensive outpatient program, you have to have a chemical dependency evaluation that states you need that level of care. I know it's confusing to those of us who work in it, let alone.
So there are some state statutes which do not give us leeway.
Yes, that is they're called the Title 206 regs.
Okay, now I want to address the issue of the system, starting at the state level, the statutes, DHHS. There are certain things which therapists and assessments, checklists for assessments, do not understand, do not take into account. And from personal experiences with close personal experience with 3 different people that have been in the system, and maybe some of them are still are. What I hear you saying, and what I've seen done, and tried to be a part of over quite a few different years, people listen, therapists listen, officials listen, but they don't hear. You don't hear that, wow, boy, somebody that's detained at the corrections center or the Douglas County Jail probably develop a mental illness while they're in there because of what goes on in there that we don't hear about unless you know somebody that's been there. But those people maybe aren't getting any help. They were maybe not mentally ill or an alcohol substance abuse person before they went in. But once they got in there, sleeping on the floor on a makeshift cot with a rubber mat and listening to all the yelling and the fighting and all the banging on the doors, develop a mental illness. One person I know very closely had to bang on the doors to get a guard's attention to say, I'm sorry, I'm having a panic attack. Panic attack, it might be a heart attack. This is not a person that's ever been incarcerated before and not necessarily found guilty yet. But he's subjected to all that because we have a lack of staff maybe, a lack of training maybe.
Larry, I think we all in agreement.
We're all for solutions, and
Right.
that's all I'm going to say.
Okay.
Okay.
I was just wondering if there was
Is
a
the
question.
therapists
Is there
don't
a question?
necessarily
I understand what
solve
you're
it.
saying. Okay,
Okay.
thank you.
Thank you.
You can't do it overnight.
I
You
got you.
can't do it in a 1-hour assessment.
Right.
Thank you.
Okay, anyone else? Thank you very much. This is very good. Appreciate it. I look forward to that information. You can just email that to me. That'd be great.
Okay, will
Will do, thank you.
So we have one more item. Erin Nelson, the interim administrator of Douglas County Health Center, joining us today. Do you want to give us your
Sure.
presentation?
Yeah, mine's just gonna be an informal presentation. We don't have direct community mental health services for mental, but they do affect the services that we provide. So the pharmacy provides all the outpatient meds and the inpatient meds for CMHC. I had a meeting yesterday with our GPO, and in the state of Nebraska, we're number 2 as far as purchase. So 1.3 million out of our $2.5 million budget pays for psychotropics across all, for the youth center, for CMHC, primary health care, long-term care. So we're hugely invested there.
Who was number one?
Corrections.
Our-
Yeah, Lincoln.
Lincoln,
Correction.
okay.
Yeah,
So we're number 1?
we're number 2.
We're number 2.
Yeah, Lincoln Corrections is number 1.
Okay. Well, that's an interesting phenomenon. I think that Douglas County Health Center in and of itself is the largest of its size in the state, is that
For
correct?
long-term care, yes.
Yes.
254 beds, about 100 of the beds, I would say, the folks that reside there have some kind of mental illness, oftentimes in addition to something else going on. Their behaviors is usually what ends up bringing them to us, because the other facilities choose not to deal with them or can't. So it does affect our staffing and our quality measures, because CMS measures how much psychotropic meds you use within the facility, and ours is double the state average. So we're at like 34, 35, the state is at 17%.
That's because of our patient population?
So it's something we carefully monitor with the Jerry psych doctors to try to get people off the meds. They especially focus on those in the dementia area because they don't want to use meds as restraints. But anybody that has schizophrenia or Huntington's are excluded from the numbers when they calculate it for CMS. So,
Do we have percentage schizophrenia population?
I think last we counted was about 20% of our folks.
Why aren't they, I'm sorry, but that's kind of counterintuitive. Why wouldn't they be included in the overall percentage of psychotropic medication?
Because
recipients?
if they're mentally ill and they have a diagnosis as such, they exclude them from, they're trying to basically look at nursing homes to make sure they're not using medications as a way to restrain or to
Okay.
control.
Well, and you do a great job over there, and we're very proud of Douglas County Health Center and the service that it provides to our community. You are sitting in the interim position, and we're in the process of determining where we go forward from there. But, you know, we just wanted to kind of get an overview of where we are currently. We had this discussion yesterday at the trustees relative to the Seam Johnson report on the Douglas County Health Center and the Medicaid long-term care rate changes. It appeared from that discussion that, at least for now, we would be receiving an increase in our rate of compensation over the last couple of years, which has been flat, 0.
Correct.
And going forward, I think that the rate increase for us would be something like 6% year to year.
6%, yeah.
Excuse me, that wasn't for us though, that was for the state Medicaid fund, and
Well, our
it's,
reimbursement was going up for Douglas County.
it's going up
6%,
6%
so-
as well?
Yeah, so we'll be at $232 a day.
Because when they were talking about the rural, urban.
Yeah, that's not coming into play yet, that's all just in talk right now.
Okay,
But yeah, our reimbursement for this year and next will be good.
thank you.
Yeah.
So if we were to, you know, quantify that into system-wide dollars for us, what kind of an increase are we talking about, if you know?
Well, 75% of our beds are Medicaid,
Right.
and we are about 90% occupancy, about 254. So on average, we have about 225 folks to 230. So that's an extra $30 a day. So I think we have 6,000 residence days a month. So pretty decent.
Okay. You know, we're coming up on our budget and approving that, and so, you know, this kind of plays into that. It's very good news for us, but you know, I'm very, very interested in quantifying that as much as possible. And from our previous discussion, I don't expect you to have the numbers in your back
No,
pocket.
I can
But
come
if
up
you
with a number.
could,
Sure.
yeah, that would be huge. We have, I think a budget discussion, is it next week, Joe?
A vote.
So if
Okay.
you get something to us, that would be.
Sure.
In addition to the Medicaid reimbursement increases, have there been any changes in any other reimbursement levels that we're receiving from anyplace else?
The only other change that'll be coming is through, our therapy reimbursement that we do for Med A and Med B patients. It actually should improve our reimbursement maybe by about 5 to 6% with the new calculations.
Great. Would that be quantifiable, like we were talking about the Medicaid
Yeah, we have
reimbursement?
those numbers as well.
That'd be great if you could
Sure.
get that. Well, unless you have something to add, I'd like to conclude these
No,
within
that's fine.
60 minutes, and I think we're coming right up on that. This has been great. Thank you very much.
Yes, thank you.
Thank you. Anybody? We are adjourned. Thank you.